All right. So today we're talking about the thoracic wall and cavity. And of course, we learned in the first 2 units that the thoracic skeleton gives attachment for the upper limb. And that's sort of largely how we considered it. In Unit 3, we're going to consider the thoracic wall, that is the bones and the muscles, in terms of its own movements, and particularly those related to breathing, as well as its roles in protecting and accessing the organs it contains. So here are the learning outcomes, and in this short video we'll start with learning outcome 1 here, talking about the joints and the muscles that contribute to breathing movements. Now, movements of the bones and joints of the thoracic wall are frequent, and perhaps hopefully incessant, but small during normal breathing. And any disturbance that reduces the mobility of these joints or compromises the integrity of the thoracic cage impairs breathing. And you know this if you've ever broken a rib. So any tiny movement when you have a broken rib, including almost every breath, is painful. In deep breathing, the thoracic cage moves more dramatically, and impairments are more obvious. So you know this too, if you've ever had a bone break in your thoracic cage, breathing deeply, such as during physical exertion or just intentionally, hurts more. Now, when we think about the joints of the thoracic cage where the movement is actually happening, it's in 2 places, anteriorly and posteriorly. So anteriorly, we have sternocostal joints, and posteriorly, we have costovertebral joints linking the ribs to the vertebrae. Now, the sternocostal joints are sort of all somewhat similar. I mean, there are differences, but they permit slight movements and allow the rib cage to expand. The costovertebral joints, we're going to learn in a bit more detail. They actually vary in how they move as you move rostrally to caudally down the thoracic cage. So, for example, the articular surfaces we're going to look specifically at the costotransverse joints here. So the articulation between the rib and the transverse processes of the adjacent vertebrae. And so the articular surfaces on the tubercles of ribs 1 to 6, as we're looking at here, are convex. And they fit into concavities on the transverse processes of the same number of ribs. So here we're looking at rib 6 articulating with the transverse process of T6, and rib 7 articulating with the transverse process of T7. And what you see when you take an axial cut through this joint along its longitudinal axis, so this transverse axis is shown in red here, is that the ribs rotate at the transverse process. And what that joint arrangement, that anatomical arrangement creates is elevation and depression of the sternal ends of the rib in the sagittal plane. So that's a lot of confusing. It's a confusing sentence, but if you put your hand on your sternum and take a deep breath, you will feel your thoracic cage expand anteriorly. And this is what's known as the pump handle movement. Now, the pump handle movement analogy works better if you know what a old-fashioned pump looks like. And so an old-fashioned pump, such as you still see in some BC campgrounds, looks like this. So the pump handle movement is the movement in which the upper portion of the rib cage expands anteriorly. And it's facilitated by these costotransverse joints in which that allow the neck of the rib to rotate. And in this analogy, it's really important to realize that the sternum is the pump handle. And so the chest expands primarily in the anterior-posterior direction in the upper thoracic cage. Now, In contrast, the joints, the lower costal transverse joints, are gliding joints. So the articular surfaces on the tubercles of ribs 7 to 10 are flat, and these flat tubercles glide over flat transverse processes of the same numbered vertebrae. And so rather than rotating at that joint, these ribs essentially glide over the transverse processes. And what this motion produces is primarily expansion of the lower thoracic cage in the transverse or horizontal plane. And we call this the bucket handle movement. And so if you put your hands on your lower ribs and take a deep breath, you should feel that most of the expansion is occurring laterally. And so in this analogy, it's of course important to realize that the lower ribs expand like a bucket handle. And so that the lower thoracic cage, if you take enforced inspiration, which is what we just did, taking an intentionally deep breath, expands the lower thoracic cage primarily laterally and the upper thoracic cage primarily anteriorly. And it's the combination of those movements that expands the rib cage to create the extra volume for forced inspiration. Now, the prime mover of inspiration, resting or forced, is, I hope you're very familiar with, the diaphragm. So it is the diaphragm that primarily achieves these movements. And the diaphragm is, like this little yoga website reference, the diaphragm is shaped a bit like a parachute, and it actually does, that works. It divides the thoracic cavity from the abdominal cavity, and it originates broadly all around the edges of the thoracic cage. So it originates posteriorly on the lumbar vertebrae. You will see references to the right and left crew, and that's the root, the posterior root of the diaphragm as it arises from those lumbar vertebrae. It originates from the lower ribs and from the xiphoid process anteriorly. And so it has these broad origins all around the inferior part of the thoracic cage, and they all converge centrally on a central tendon. And that's when you see these drawings of the diaphragm and there's a white sort of middle, that's the central tendon. So I'll show you some views of that to see what I mean in a moment. The first thing to appreciate about the diaphragm is that it's innervated by the phrenic nerves, and there is a left, shown in yellow, and right phrenic nerve. They descend bilaterally, and so the diaphragm is actually two domes or two hemimuscles. So the right dome innervated by the right phrenic nerve, the left dome innervated by the left phrenic nerve. So you can actually have hemidiaphragmatic paralysis, which would result from damage to one phrenic nerve. The phrenic nerve descends from spinal cord segments C3, C4, and C5. So those spinal cord segments house the motor neurons for the diaphragm, and the mnemonic I use is C345, keeps the diaphragm alive. And indeed the person, because if you stop breathing, things tend to go south very quickly. Now, here we are in an inferior view of the diaphragm, and I've got various images of this for your viewing pleasure. This is obviously a very cartoonish image, but what you can see is that there's origins of diaphragmatic muscle fibers all the way around the inferior part of the thoracic cage, including the distal tip of the sternum, the xiphoid process, all the way around from ribs and the lumbar vertebrae here. And they sweep in and converge centrally on this white central tendon. Now, of course, things still have to pass through the diaphragm. Otherwise, they can't access the abdomen. And among the things that pass through, the sort of notable passings are the vena cava, the inferior vena cava, the esophagus, and the abdominal aorta. And so at this point is when this artery makes the transition from the descending aorta to the abdominal aorta after it passes through the diaphragm. This is what this schematic is representing. This is it in a cadaver. So again, in an inferior view, and you can see the fibers originating from all the way around the bottom of the thoracic cage and sweeping toward this central tendon. And you can see that they are, this is the vena cava foramen, and sometimes they're called hiati or hiatus. Sometimes they're called foramina or foramen. I think we use hiatus primarily in the course. And you can see that the relative order anterior to posterior is vena cava, esophagus, and abdominal aorta. Okay, so the muscles of the thoracic cage can be described both anatomically and functionally. And as we already know, some of the muscles that attach to the thoracic cage would be best described as axio-appendicular. They originate on the axial skeleton, but extend and insert to bones of the upper limb. And of course, pec major is one of these, as is latissimus dorsi. Some of these also have accessory roles in breathing, and the most important muscle in that category might be pec minor. However, true muscles of the thoracic cage originate and insert on the thoracic skeleton. So we've already talked about the diaphragm, which is an intrinsically axial muscle, and of course the prime mover of all types of ventilation. And I'll stop here and make the point that I would like to use the term ventilation for all the movements of breathing, any movement that achieves air coming into the lungs, and respiration for the term of gas exchange at the level of the alveoli. So I know I mix it up and everyone does this, but let's try to describe the movements of breathing as ventilation and the cellular processes of gas exchange as respiration. So an example of a true thoracic wall muscle in terms of its origin and insertion with a poorly defined function is serratus posterior superior and serratus posterior inferior. These were once thought to be accessory breathing muscles. Now they're more considered proprioceptive. They have a high density of proprioceptive nerve endings, and they actually are located at the transitions between movable portions of the spine, like cervical and lumbar, and the relatively immovable thoracic spine. So, serratus posterior superior is located at the cervicothoracic junction, and serratus posterior inferior is located at the thoracolumbar junction. Both muscles originate medially at the spinous processes and insert on the borders of the ribs. And so in addition to giving us proprioceptive feedback at these junctions, they're thought now to be involved in myofascial pain syndromes, but they're no longer generally considered accessory muscles of ventilation. Instead, the best characterized true sort of muscles of the thoracic cage and accessory muscles of ventilation are the intercostals. Now, most people agree on the role of the intercostals in breathing movements. And if you're wondering how people are still, in this day of modern science, arguing about which muscle does what when we breathe, consider the challenges of recording an EMG in a live person from the intercostals. So these are deep muscles that are incredibly mobile, because if your thoracic cage stops moving, you're not breathing. And so these are challenging things to study. But we have sort of agreed that the external intercostals and two divisions of internal intercostals crucially contribute to breathing. So the external intercostals are the most superficial layer, and they're arranged at roughly 90 degrees in terms of fiber orientation to the internal intercostals. The internal intercostals exist in two separate functional divisions: the bony internal intercostals that connect adjacent ribs, and the cartilaginous internal intercostals that connect adjacent chondral cartilages. And those two divisions have two different roles. So when we talk about inspiration or inhaling movements, so expansion of the thoracic cage, the main accessory muscle for this is the external intercostals. So the external intercostals elevate the ribs to enlarge the thoracic cage. The external intercostals are aided by the chondral portion of the internal intercostals, which also elevate the ribs. So in terms of expanding the thoracic cage and increasing its volume, you've got the external intercostals and the cartilage portion of the internal intercostal muscles. On the other side of the equation, if we think about expiration, so reducing the volume of the thoracic cage, and again, this would be forced, not quiet expiration, so intentional expiration. You're recruiting the internal intercostals, and only the bony portion of them act in this direction. So the bony portion of the internal intercostals, which is of course located more laterally on the thoracic cage, contributes to forced expiration, whereas the cartilaginous portion contributes to inhalation. Now, let's look first, before we look at this little sectional view of an intercostal space, let's look at this quite slightly simple one. So first you can see this is on the right side of a human, and we can make this, let's name these two adjacent ribs. So the intercostal spaces, there are 11 intercostal spaces because there are 12 ribs. And each intercostal space is named for the rib immediately above. So let's describe this as rib 4 and this as rib 5. This would be the fourth intercostal space. And you can see the superficial to deep arrangement of these muscles. So the external intercostal muscle, most superficial, and the fibers at right angles to the internal intercostal muscle, and deep to that again and partially sheltered by the rib are the intercostal vein, artery, and nerve that travel in this space. And you can see that they are sort of cushioned, particularly the vasculature, are cushioned in behind the groove of the rib. And so deep to the internal intercostals and partially protected by the superior rib of the intercostal space. The intercostal nerve is most exposed in the intercostal space, so it is most vulnerable to damage at that level. And deep to the internal intercostals, we do have a layer of sort of ill-defined innermost intercostal muscles. And the innermost intercostal muscles are often in cadavers present as slips of muscle. So they're shown here in a very convincing rostrocaudal anterior superior orientation as a solid band of muscle. That's not often the way they appear. So we're not going to talk much about the function of them, other than you should know that in most portions of each intercostal space, there are 3 layers: external, internal, and innermost. And the innermost and the internals create a muscular tunnel for the vein, artery, and nerve. Oops. All right. So I just wanted to close with a short word on origins and insertions of the intercostals. And this is one of the most variable thing amongst sources. But what makes sense to me is just to describe these external and internal intercostals, knowing that the latter is involved in 2 separate functional movements, depending on if it's bony or chondral, or cartilaginous. We describe the origins and insertions conventionally based on their action, that is, moving the static, the insertion point toward the origin. So if we go back here, to this diagram. I've added some text to make sure I don't say this backwards and cause horrible confusion. And so on this diagram, the arrows indicate the direction of movement or muscle shortening. And so if you reverse those arrows, then you get a good idea of muscle fiber direction as it sweeps from origin to insertion. For example, for the external intercostals, they originate from the inferior border of a rib, and the fibers pass inferomedially, that is inferiorly and medially, to insert along the superior border of the rib below. And so the origin is rostral, the insertion is caudal, and when the muscle fiber shortens, it pulls the rib cage in this upward direction, upward and outward, and moves the insertion toward the origin. And you can take the same as true for the cartilaginous division of the intercostals. That is that their insertion rib will be caudal to the rib of origin. And that allows, when they contract, to move the insertion toward the origin. The bony internal intercostals, on the other hand, we can take as originating from the superior border of a caudal rib, and the fibers passing superior medially to insert along the inferior border of the rib above. And in that way, if you think of the fiber directors traveling exactly opposite to this direction of motion, when the bony portion of the internal intercostals contract, it will pull the insertion toward the origin, pulling the rib cage down and in. And I know that sounds complicated, but hopefully it's intuitive. Again, you're always moving insertion to origin to achieve the movement that's indicated by these arrows for both of the divisions of muscles of breathing. And just look at this slightly more detailed schematic of the intercostal space. So again, if this were rib 4 and this were rib 5, this would be the fourth intercostal space. There's 3 distinct layers of intercostals filling this space, all deep to the muscles we've discussed so far. So for example, this is an anterior view. This would be the left anterior intercostal space, or left anterior view of the fourth intercostal space. And this is serratus anterior. And you can see serratus anterior inserts superficially on the body of the rib, and the external intercostals attach deep to muscles like serratus anterior. So really attaching to the borders of the ribs at varying depths as you go from external to internal to innermost. Here is the intercostal nerve, artery, and vein. Those are the main branches that reside at the rostral part of each intercostal space. And there are also collateral branches. And so I'll insert another slide on this because I don't know if you've seen this diagram, but these are the nerves, arteries, and veins that originate posteriorly and sweep anteriorly within each intercostal space. And finally, deep to all of that again, which we're going to talk about in sort of our next lecture, are the pleural cavities and the lungs. And the pleural cavity is critical because this pleural cavity is what maintains continuity between the lungs and the muscles that govern ventilation. And so when this pleural cavity is compromised, you lose that continuity, and the expansion of the rib cage is no longer coupled to expansion of the lungs, and ventilation and breathing is compromised as a result. Oh, finally, I'm going to show you one more posterior view. The reason to see this posterior view is to remember that the intercostal space extends all the way posteriorly. And so here you can see the posterior origin of the intercostal vessels. They originate here and sweep anterolaterally. And you can see in this case, the 9th intercostal space is filled with intercostal muscles all the way from anterior to posterior. And so just remembering that this arrangement of the intercostals is consistent for the whole circumference of the thoracic cage.